discuss the etiology, clinical features, investigations, and management of rheumatoid arthritis. Rheumatoid arthritis is a chronic autoimmune disease primarily involving joints. Its main feature is symmetric peripheral polyarthritis. Rheumatoid arthritis occurs all over the world. Highest prevalence is in Pima Indians of Arizona and lowest in Black Africans and Chinese. It is more common in females. Etiology. The exact cause of rheumatoid arthritis is unknown. It is an autoimmune disease and is thought to result from the interaction between patient's genotype and environment. Rheumatoid arthritis might be a manifestation of the response to an infectious agent in a genetically susceptible host. A number of infectious agents has been suspected, which include Mycoplasma, Epstein-Barr virus, EBV, cytomegalovirus, parvovirus, and rubella virus. Evidence for genetic predisposition is suggested by higher incidence of rheumatoid arthritis in monozygotic twins than in dizygotic twins, and increased frequency of disease in first degree relatives of patients. The risk of developing rheumatoid arthritis has been associated with HLA-DRB1 alleles. Female gender and cigarette smoking are risk factors for the development of rheumatoid arthritis. Changes in the composition of intestinal bacteria have also been implicated in rheumatoid arthritis. Pathology. Rheumatoid arthritis is characterized by chronic inflammation, granuloma formation, and joint destruction. The earliest change is swelling and congestion of the synovial membrane, which becomes infiltrated with lymphocytes, CD4 plus T cells, plasma cells, and macrophages. These inflammatory cells release cytokines, which stimulate the activation, proliferation, and differentiation of B cells into antibody producing plasma cells. These plasma cells produce antibodies, rheumatoid factor, anti-cyclic citrullinated peptide, anti-CCP, which contribute to joint destruction. Inflammation of synovium leads to synovial hypertrophy and effusion of synovial fluid into the joint space, leading to joint swelling. There is formation of inflammatory granulation tissue, that is pannus, which spreads over and under the articular cartilage and damages it. Involved joint may develop fibrous or bony ankylosis. Muscles adjacent to inflamed joints atrophy, and there may be focal infiltration with lymphocytes. Subcutaneous nodules consist of central area of fibrinoid necrosis surrounded by radially arranged mononuclear cells with strands of collagen. Rheumatoid vasculitis involves medium and small arteries and venules with infiltration by lymphocytes. Clinical features. Articular features. Rheumatoid arthritis is more common in females. The peak age of onset is in the fourth decade in females and slightly later in males. The onset can be monoarticular, oligoarticular, or polyarticular. The most common presentation is insidious in onset of symmetric polyarthritis. The joints involved are wrist, metacarpophalangeal joints, wrist, proximal interpharyngeal joints, elbow, shoulder, knee, ankle, and MTP joints. Wrists and metacarpophalangeal joints of index and middle fingers are most commonly involved. The distal interphalangeal joints of the fingers are usually spared. Symmetrical joint involvement is common in middle-aged women. Acute onset with asymmetrical polyarthritis is more often seen in elderly patients. Asymmetrical presentation becomes symmetrical as the disease progresses. In the palindromic onset type, joints are affected and resolve completely within hours to days and recur after a period of time. This type may finally evolve into classical symmetrical polyarticular pattern. Predominant symptoms are stiffness and swelling of involved joints. Morning stiffness is a common feature of rheumatoid arthritis and is defined as slowness or a difficulty moving the joints when getting out of bed or after staying in one position for too long. Stiffness usually lasts more than 1 hour. Joint deformities may be present and often observed in hand. Swellings of PIP joints give rise to spindle-shaped appearance of fingers. The DIP joints are usually spare. In osteoarthritis, DIP joints are involved. Swan neck deformities in the fingers is due to extension of the PIP joints and flexion of DIP joints. Boutonniere deformities is due to flexion of the PIP joints and extension of DIP joints. Extra-articular features. Systemic features: low-grade fever, weight loss, loss of appetite and fatigue. Musculoskeletal features: muscle wasting, bursitis, tenosynovitis, osteoporosis. Osteoporosis and muscle wasting result from systemic inflammation. Skin. Rheumatoid nodules. These are subcutaneous nodules seen in 25% of patients with rheumatoid arthritis. They are firm, round masses and vary in size. They are seen over the pressure points like the olecranon process, scapula, sacrum, Achilles tendon and the occiput. Visceral structures like heart, lungs and CNS may also be involved. Most skin nodules do not require any treatment. For painful nodules or those that interfere with the joint motion or impinge upon nerves, local injection with a mixture of steroid and local anesthetic may cause regression. Other skin manifestations are ulcers, vasculitis, gangrene, and pyoderma gangrenosum. Eye features include episcleritis and scleritis. Respiratory features: pleural effusion is usually bilateral with a low pleural fluid glucose. Fibrosing alveolitis, nodules, bronchiolitis. Kaplan's syndrome. This is a combination of rheumatoid arthritis and pneumoconiosis, which manifests as multiple nodules in the lungs and interstitial lung disease. This is seen in coal miners. Cardiac features: pericarditis, myocarditis, and endocarditis. Coronary vasculitis can lead to myocardial infarction. Aortitis or aortic regurgitation. Conduction disturbances including incomplete heart block. Hematological or reticuloendothelial features. Normocytic, normochromic anemia, thrombocytosis, eosinophilia, splenomegaly, that is Felty's syndrome, neurological features, compression neuropathies. These are due to compression of peripheral nerves by hypertrophied synovium or joint subluxation. For example, carpal and tarsal tunnel syndromes. Cervical cord compression due to subluxation of atlantoaxial joint or at a subaxial level. Peripheral neuropathy, mononeuritis multiplex. Other features include systemic vasculitis, for example, skin, CNS, lungs, etc. Amyloidosis is a rare complication of chronic active disease and usually presents with a nephrotic syndrome. Diagnosis of rheumatoid arthritis. Diagnosis should be suspected in any patient who presents with a chronic symmetric polyarthritis. American College of Rheumatology ACR and the European League Against Rheumatism EULAR criteria for the classification of rheumatoid arthritis is as follows. Diagnostic criteria for rheumatoid arthritis. Four features are included in this diagnostic criteria of rheumatoid arthritis, which are joint involvement, serology, acute phase reactants, duration of symptoms, and the score is given accordance with the features. Coming to the joint involvement, if one large joint, that is shoulder, elbow, hip, knee, ankle, is involved, then we'll give 0 score. If 2 to 10 large joints are involved, we'll give 1 score. 1 to 3 small joints, that is MCP, PIP, thumb, IP, MTP, wrists are involved, we'll give 2 score. 4 to 10 small joints, 3 score. More than 10 joints, at least 1 small joint, 5 score. Coming to the serological features, negative rheumatoid factor and negative anti-CCP, that is anti-citrulline protein antibody, will give 0 score. Low positive rheumatoid factor or a low positive anti-CCP antibodies will give 2 score. High positive rheumatoid factor or a high positive anti-CCP antibodies will give 3 score. Coming to the acute phase reactants, normal CRP and normal ESR will give 0 score. Abnormal CRP or abnormal ESR will give 1 score. Duration of symptoms less than 6 weeks will give 0 score. More than or equals to 6 weeks will give 1 score. A score of 6 or more fulfills the requirements for definite rheumatoid arthritis. A score of less than 6 suggests possible rheumatoid arthritis which requires follow-up. Coming to the investigations, chronic normocytic normochromic anemia, ESR and CRP are elevated. Rheumatoid factor is present in more than 80% of the cases. Anticyclic citrulinated peptide, that is anti-CCP antibody, this is more specific than rheumatoid factor for the diagnosis of rheumatoid arthritis. Antinuclear antibodies, that is ANA, can be found in 40% of the cases. Synovial fluid analysis usually shows a white cell count of 5000 to 20,000 per cubic mm with predominant neutrophils. Synovial fluid glucose is usually normal but may be low. X-rays of the hands, wrists and both feet show periarticular osteopenia and marginal non-proliferative erosions. Bone erosions may not be seen initially up to 6 months. Coming to the management, the goals of treatment are 1. Relief of pain, 2. Reduction of inflammation, 3. Protection of articular structures, 4. maintenance of function, and 5. Control of systemic involvement. Pharmacologic therapy include analgesics, DMARDs, that is disease modifying anti-rheumatic drugs, steroids, biologic agents, immunosuppressive agents. Coming to the analgesics, acetaminophen, that is paracetamol, and NSAIDs, diclofenac, ibuprofen, aceclofenac have both analgesic and anti-inflammatory properties but do not alter disease outcomes. Opioid analgesics such as propoxyphene, tramadol, oxycodone, etc. are also useful to control pain. Topical analgesic preparations, example capsaicin or a diclofenac, can be combined along with oral agents. Coming to the DMARDs, which itself is a 5-mark question, disease modifying anti rheumatic drugs. These are slow acting anti rheumatic drugs. They can reduce or prevent joint damage, preserve joint integrity and function, and maintain economic productivity. These include hydroxychloroquine, sulfasalazine, methotrexate, and leflunomide. Out of these, methotrexate and hydroxychloroquine are commonly used. Other less commonly used DMARDs are gold salts, D-penicillamine, azathioprine, and cyclosporine. Methotrexate is given once a week in a dose of 7.5 to 25 mg per week. Folic acid should be given along with methotrexate to prevent hematological side effects. Hydroxychloroquine is given at a dose of 200 to 400 mg daily. Sulfasalazine is given at a dose of 1 gram twice daily. Steroids examples are prednisolone, triamcinolone, etc. These are used to suppress inflammation and may be administered orally, intravenously, or by intra-articular injection. Prednisolone 7.5 mg per day or less is relatively safe and can be used for extended periods of time. Doses higher than 7.5 mg per day should be used for the shortest time possible. Steroids are especially useful during initial control of the disease and during flare-ups. Biologic agents. These are biologic response modifiers and have immunosuppressive effect. These are anti-TNF agents such as adalimumab, etanercept, and infliximab. Non-TNF inhibitors are tocilizumab, that is interleukin 6 inhibitor, abatacept, that is inhibits T cell co-stimulation, and rituximab, anti-B cell, rituximab. Immunosuppressive agents, examples are azathioprine and cyclophosphamide. These are third-line agents and are rarely used. They have serious side effects. IV cyclophosphamide may be life-saving in acute vasculitis causing organ damage. Non-pharmacological measures. Patient education and counseling. Patient should be explained about the chronic nature of disease and the need for long-term therapy. The side effects of drugs should be explained and the need for follow-up stressed. Rest. This helps during acute arthritis and during flare-ups. Exercise. Lack of exercise can result in loss of joint mobility, contractures, and muscle atrophy. Patients should exercise regularly to prevent and reverse these problems. Physiotherapy. This involves application of heat or cold to relieve pain or stiffness, ultrasound to tenosynovitis, passive and active exercises to improve and maintain joint motion range. Surgery. Synovectomy of the wrist or finger tendon sheaths may be required for pain relief or to prevent tendon rupture when medical therapy fails. Osteotomy, arthrodesis, or arthroplasties may be required in advanced disease when joint destruction and deformities take place.